Hello, everyone. I'm Dr. Angela Mattke, and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at Mayo Clinic Children's Center in Rochester, Minnesota, and host of this show about pediatric health topics where we take and answer your questions live. The liver is the largest organ in our body, and it also performs many critical functions essential for life. Today, we will be joined by three experts from Mayo Clinic Children's Center to discuss more about what the liver does, what happens when it's not functioning normally, including a discussion about pediatric liver failure and liver transplantation. Our first two guests, Dr. Samar Ibrahim and Dr. Sara Hassan, are both pediatric gastroenterologists and hepatologists at Mayo Clinic Children's Center and experts in pediatric liver transplantation. Dr. Ibrahim is also the medical director of the Pediatric Liver Transplant Program at Mayo Clinic Children's Center. Our third guest is Dr. Timucin Taner, a liver transplant surgeon at Mayo Clinic. We're excited they can all join us today via Zoom. Please send in your questions about pediatric liver disease and pediatric liver transplantation, and we will try our best to review them during the live broadcast today. However, remember, we cannot offer specific medical advice for your family's circumstances. So Dr. Hassan, Dr. Ibrahim, Dr. Taner, thank you so much for joining us today.
Thank you. We're excited to be here.
Thank you, Angela.
You know, last time when Dr. Hassan had joined us, she was really excited about the liver and basically said it's the most amazing organ in the entire body. I think you even made some references to a certain pop star. And so maybe you'll have to tell us that again. But let's start off by understanding, what does the liver do? Maybe a better question is, what does the liver not do, since it does so many important essential functions?
Thank you so much. Absolutely great question. The liver, also known the Beyonce of the body, the most hands down important organ that we have. It clears all the toxins. It makes sure that, when the blood comes to your brain, it's clear, it's no waste in it, and it keeps us healthy, keeps our thoughts excellent. It also produces bile. So it's really incredibly important for digestion. It's the only way that we can actually grow, and kiddos with liver disease don't grow as well because many of those functions. The liver also produces a lot of proteins. It makes sure that the blood is not too thick or not too thin. And it stores some of the sugars and contributes to sugar regulation. So if you ask what can the liver not do, probably very little. It's amazing.
I'd say, yeah, it's very essential to pretty much every function that kind of happens in our body in keeping us healthy. So when it's not working, patients develop symptoms called chronic liver disease or cirrhosis. So what are those things, and what are the symptoms that you would see in a child who's developing concerns with their liver function?
So go ahead.
So we as hepatologists will look for signs and symptoms of chronic liver dysfunction in patients who are known to have liver disease, including some of those related to concentration, as Dr. Hassan just said, the ammonia, which is should be cleared by the liver, would be clearance will be impaired in patients who have chronic liver dysfunction. Sometime with chronic liver disease, there will be buildup of scar tissue in the liver. So we see complication of a condition called portal hypertension, including accumulation of fluid in the belly or ascites. Sometimes patients present with a bleed, variceal bleed, among other complications that we see in patients with end-stage liver disease.
Okay. What are some of the conditions that can cause liver dysfunction, liver failure, end-stage liver disease in children? I know it's probably a little bit different than the adult population in most cases.
The way I think about it is the way how does the liver work and where are these conditions coming from? So most things that are commonly affected whenever the liver is building up is the way the ducts inside the liver that clear the bile are working. So if we have an injury to that, which is roughly more common in the patients that we see, it's called biliary atresia, and that can lead to severe liver disease. There are other conditions that can be inherited, like alpha-1 antitrypsin. There are conditions where the body is attacking the liver. It's a little bit more rare, but it can happen. So it's like autoimmune hepatitis, the same way where the body can attack the thyroid, it can attack the liver as well. And then there are storage disorders, cancers, of course, and then now we're seeing a lot more of it, steatohepatitis or NASH, which is really the end-stage form of fatty liver.
You mentioned storage diseases. Can you elaborate a little bit more on that? What does that mean?
So storage diseases are certain genetic and metabolic diseases where we have a lot of excess, for example, the glycogen storage disease or lysosomal storage disease. These are diseases where we have an excess of material storage of proteins or sugars or glucoses in the liver that is causing a dysfunction. There's so much of it that it impairs a lot of the organs, including the liver and the gut, that can cause severe disease.
So, Dr. Ibrahim, when I think about some type of organ failure, there's a lot of different things that we can do to support the body's functioning when that organ is failing. So with heart dysfunction, there's ways that we can boost the heart's function and performance. With kidney failure, there's dialysis. When the liver is not working, do we have options? Is there anything we can do to try and boost the performance or help clear these toxins that the liver is really critical for doing?
Yeah. So basically, we don't have an equivalent of dialysis for supporting chronic liver failure. Our treatment is mainly in the form of preventing complications that are a sequelae of chronic liver dysfunction. In acute setting, there are some conditions that the liver might recover by itself. So not every patient with acute liver failure will necessarily need a liver transplant. So supportive therapy and preventing of infection are the mainstay. We sometimes use Mars as a bridge, but the data have not been solid that we can use this system to prevent a transplant. As patients progress to a reversible stage of liver failure, liver transplantation remain the mainstay of therapy.
What is Mars? Is it a planet or is it something that helps with the liver?
So I'm going to defer to that to Dr. Timucin Taner, since this is a system to support patients in acute liver failure. It has been used also in hepatic encephalopathy to clear ammonia in some clinical trial in adults. But its use in pediatric population is limited. We have used it in specific setting where patients are not a good candidate for transplant, but we don't have good data to solidify that this is the way to approach our patient population with acute liver failure.
Yeah, Dr. Ibrahim is absolutely right. There is no equivalent of dialysis for liver patients. Mars is an artificial dialysis system in which patients' blood is circulated through what we call an albumin channel. So albumin is a protein that's made in the liver, and the cirrhotic kids with the scarred liver don't have enough of because the liver is not making it. When we can circulate their blood through this albumin channel, it sort of sustains them a little bit while they're waiting for a transplant, or can help with some of the liver functions, definitely not all the liver functions, because as Sara said, it's Beyonce. You can't just replace Beyonce. So
she's irreplaceable. That's the truth. Well, before we move on to talking about transplant, because it seems like that's the next logical step for these patients. Dr. Hassan, you had mentioned fatty liver disease or NELF. What would be kind of the process of helping patients who are experiencing that? That was an audience question that just came in.
So for many patients who have excess fat deposition in the liver, the first step is to really try to melt that fat, and at the same time assess how the fat deposition is causing irritation to the liver. The more irritation to the liver, the more these cells are angry, and so we have an elevation in the liver enzymes. But more importantly, the more these livers think that there is a problem and they're trying to repair, so they lay down the scar tissue, and the more scar tissue we have, the more fibrosis we have. So as soon as we are seeing fatty liver, we are trying to kind of halt the process and put it on reverse, melting that fat as soon as possible, assessing how much cirrhosis or fibrosis we have, and preventing more scar tissue and more damage to occur. If we are in the case where there's a ton of scar tissue and we are not able to reverse it, then we have to look at different ways, and transplant is definitely an indication for it. And it's becoming, and Dr. Taner, you can correct me, is one of the most important indications for the adult world. So we are indirectly fueling this as our kids transition to adults, and we need to protect them and save them.
So there are ways to reverse it potentially if the scarring and the damage is not too severe.
There are some ways to
Okay.
reverse. Absolutely. The liver regenerates. It's Beyonce, it can bounce back. And then if it doesn't, liver transplant.
Okay. All right. Well, let's talk about liver transplant. How do you know when you get to the point that this is something that needs to be considered? Are there certain indications or lists that you would go through in evaluating a patient to determine should we put them on the transplant list or not?
I can start, and my colleague can join me. So liver transplantation is really a life-changing experience, and it's a major operation. We don't make this decision lightly. There is an evaluation process and a selection committee to justify the need of liver transplantation, where the risk of living with the native liver is beyond having the transplant surgery. And most of these cases are acute liver failure with no chance of recovery based on close follow-up in the intensive care unit that gave us this assessment. Chronic liver dysfunction that's irreversible due to severe scar tissue buildup, and complication of what we call portal hypertension. The most important and feared one is this catastrophic bleed that sometimes is difficult to control in spite of every endoscopic intervention we could do. Sometimes quality of life is a major determinant. Some patients with chronic liver disease develop severe itching. They're even like suicidal. So we have done liver transplantation for quality of life measures, not necessarily for life-threatening conditions. And this is because this quality of life component is really important for the patient to survive and have a good life, basically. And I will turn to my colleagues to add on.
Yeah, one thing I would add is as soon as we are thinking transplant, we usually involve the families early on. So transplant is absolutely like what Dr. Ibrahim said, it's a life-changing measure. And this is often for the kids who have really end-stage liver disease, meaning they're yellow, they're itching, they have a lot of fluids in their belly, their breathing is impaired, they may not be growing as much, or for patients who have cancers in their liver, or if they have acute liver failure. The process is essentially we try to make sure how fast and how well we can get a transplant, and we assess we try to set our patients and our families up for success. It's rather a fair process. It's a discussion. It's not a one decision person. And as soon as we're thinking about this, they will meet the transplant family, and I think that's huge.
Yeah, absolutely. So you mentioned some of the indications for it. Is there one kind of overriding and common indication in pediatrics, or is it just very variable about like what diseases or indications would warrant it?
Yeah. So I can start biliary atresia, as it's well known to most pediatricians, the most common indication of liver transplantation in the pediatric age group. The science is out there. It's multifactorial. People think that it's an immune-mediated process. It might be congenital. It starts even before birth, where there is like fibrous tissue and inflammation built up around the bile duct, causing progressive liver dysfunction. And we can speak about intervention to help this progression, including performing a Kasai procedure during the first 6 weeks of life. But most patients, even if they had the Kasai, might require a liver transplantation within the pediatric age group. And I will turn to my colleague for other indications that are really common. So if you, Dr. Hassan, if you want to speak about metabolic condition and
metabolic conditions constitute about the second most common etiology. This includes metabolic liver disease, inherited etiologies, alpha-1 antitrypsin. In acute liver failure is also a common indication. This is where there is an injury to the liver, and all of a sudden the liver is unable to perform its functions to the point of no return, and this is irreversible. So we have to intervene to save that patient's life. In more rare cases, there's also hepatoblastoma, which is a specific cancer to the liver. There's hepatocellular carcinoma. It's a different cancer, but also affects the liver, and it needs emergent treatments. There are certain diseases that are not limited to the liver, but can manifest in the liver, and those need transplantation as well. This is, for example, cystic fibrosis. They can have very severe and advanced liver disease, and those need transplantations as well. I think those are about the most common etiologies.
Most of these are, Angela, probably things that the audience have not heard before, and that's the importance of this. Most new parents don't expect their kids to have a prolonged period of jaundice or not growing. So these come as a shock to the parents, unfortunately. So the message here is, we have expertise in this, and there are some things that we can do to improve the liver. But if the liver cannot improve to a acceptable level, then the decision is made to go to the transplant.
Okay. And when you're making that decision to go to the transplant, what are the options for transplantation? Living donor, deceased donor, and like how long is that process until they actually would complete the transplant?
So I'll start. It's as both Dr. Hassan and Ibrahim said, it's a complete team approach. That's the unique thing about the transplant evaluation. We evaluate these kids who may or may not need a liver. We make decisions together, and if the decision is that there is no reasonable chance for them to have a reasonable life or growth pattern with their existing liver, then we proceed with the liver transplantation. Once that decision is made, usually the kids are placed onto the National Liver Waiting List. And National Liver Waiting List is for everyone, both kids and adult populations who are in need of a liver transplant. And the way they get the transplants or have access to these transplants is through a priority score. So these score systems, both the adult version and the pediatric version, are designed to indicate how sick the liver is and how soon the individual needs a liver transplant. So the whole process works through that the sickest person gets the available liver first. So the most common option for both the pediatric and adult populations, therefore, is to go on a list and wait for a deceased donor liver allograft based on their priority score. But there are a certain number of kids who are really sick because of their liver disease, but they don't have a priority score. That's when we start thinking about a living donor liver transplantation, because in living donor liver transplantation, the kid does not need to wait on the waiting list for a long period of time, suffering the consequences of the end-stage liver disease, and they can have a timely access to liver transplant through a living donation, which means a healthy person, a parent, somebody they know, a family friend, could donate a piece of their liver to the kid who is in need of a liver transplant.
Is there any difference in outcomes between a living donor transplant or a deceased donor allograft?
So the overall outcomes are quite similar to each other. The advantages of waiting for a deceased donor liver are that the kids get a full size match liver. So the operation is a little easier. But the disadvantage, obviously, is the time they spent waiting for a liver on the waiting list and going through the complications that may come with the liver, end-stage liver disease. So the living donor liver transplantation is technically more complicated. It involves operating on two people, including one who's completely healthy, but cuts the time to a much shorter period so the kids can start recovering from the liver transplant.
So we've talked a little bit about what this process is like, and you've mentioned, it's a very multidisciplinary process. Who do they see in this team as they're kind of going through the process or on the list waiting for a potential donor?
So I can start. It's going to be a pediatric transplant hepatologist, a pediatric surgeon. We have a pediatric infectious disease with transplant focus. We have the nurse coordinator who coordinate all the care, social worker, pharmacist, dietitian, and a lot of evaluation, including laboratory study and imaging study to assure that the anatomy is well assessed.
Is there any like ongoing frequent monitoring that they would need during this process?
The transplantation or pre-transplantation?
The pre-transplantation process.
Absolutely. As soon as they meet with the transplant family, they undergo a battery of testing and imaging just to make sure that their organs are healthy, that we don't uncover or discover other conditions, and that we assess their entire health status prior to the transplantation and see what can we optimize, what can we treat before, and what can we plan for the surgery to be successful. Most of the time, like Dr. Ibrahim mentioned, we pay very close attention to their vaccination status to make sure that we are able to, protect them as much as possible prior to transplantation, so that we prevent vaccine preventable infections, which is really an undesirable outcome to have. We also make sure that they meet with the dietitian, set goals for nutrition, make sure that they're healthy and they're strong enough despite their liver disease so that they can recover faster from a transplantation. We do echoes to their heart, we check on their labs, we make sure that their kidneys are healthy, and we process this as we go.
Is the emotional preparation for this process also one of the steps and the things that families go through to help prepare them, and the patient, and the pediatric patient especially?
Yeah, I can start, and I will turn to my colleagues. So basically, those patients have a chronic condition most of the time. The only situation is the acute liver failure, when the patient is previously healthy and they come either with for example, acetaminophen overdose that's not responsive to our standard of care, or a fulminant immune-mediated condition, or any like a known cause of acute liver failure. So those patients, there is a lot to take on and adjust, and we have the support of the team. We have a social worker on our team, and we keep close communication with the family. But patients with chronic liver disease, they are engaged, and we monitor them at a regular basis and assure their transition from the hepatology practice to the transplant practice in a timely manner, where transplant is likely to be in their best interest at that particular time point based on their disease course. Anything else, Dr. Hassan?
Yeah. I'll just add that I tell them once they're on the list, it's pretty much like you're about to give birth. The call can happen at any time. You have to have a bag ready. You have to be prepared. You have to just make sure that your phones are always charged. Make sure that you're not putting them on silent. Get excited. This is awesome. And then I tell them that they're going to come back. They're going to have a lot of tubes, a lot of things, but this is a happy event. And one of the first things that I think accidentally we say it, but I've noticed we come into the room and we look at the family and we're like, congratulations, this is amazing. And I think it shifts the focus in that room a little bit, because it is really a happy event. It is the gift of life.
Yeah. Mm-hmm. And this is another opportunity to promote, donation, because
save the life.
Yes, exactly. Yeah. This is a way to save a patient in need, especially the disease donor option through, opting in at your driver's license registration, which is the easiest way. Mm-hmm. And also to consider a living donor liver transplant. There are some programs. I would defer to Dr. Taner to speak more altruistic donor, or like pair donation. I don't know, Dr. Taner, if you want to mention this really briefly.
Sure. So I completely agree. This is the ultimate gift of life for kids who do not have a high priority score. We do living donor liver transplants, as I said, Angela, and we also do offer living donor liver transplants from altruistic donors who would like to donate a piece of their kid livers to a kid on the list waiting for a liver transplant. So we offer all those options so that kids can have a normal life.
Mm-hmm. Yeah, absolutely. The more people that can be aware, and also letting your family and friends know of your wishes too, whether you have some type of advanced directive or something along those lines, to tell people how you want to potentially help people if something catastrophic were to happen to you. So let's kind of move on to talk about so after the surgical process, what does recovery look like? And what does life look like after transplant for these kids and adolescents and families? Do they get to go back to being just normal kids with carefree, or there's some kind of ongoing monitoring and medications that are needed?
I think Dr. Hassan has done a lot of work with that, so I'll let her take on.
I'll say that it's a little bit of both. immediately after the surgery, there are lines, there are tubes, we have excessive monitoring that's happening, but our goal is to make sure that the liver is well situated in the new body, the body is accepting that liver, and that we are making sure that the immune system plays nice with this new organ. After that, we expect, a couple of days, maybe 3 to 4 days in the ICU. And then after that, they are transitioned to the floor, and then discharge is right around the corner. We ask them to stay local for about a month, just so that we can see them frequently. And the reason why we see them frequently is A, make sure that the liver is well, but B, make sure that they are not having any side effects from the immunosuppression medications, that they're tolerating it well, that their body is responding nicely to that transplantation. After that, I would say even like 6 months to a year after transplant, we are backing off a lot of those medications. And when they start with, 8 to 10, now they're on maybe 2, maybe 1, depending on the situation. It's almost like take your Tacro or take your multivitamin, I think they have a better quality of life than they started, because now they're not living with the end-stage liver disease anymore, or they're not living with that. They are breathing better, they are eating better, they are growing. If they are teenagers, they're having their menses back, that everything is kind of getting reorganized and resorted. And our goal is to get them safely to there with a little bit of help of immunosuppressants.
So you mentioned the immunosuppressants. Will that be lifelong? And like what kind of monitoring and side effects are those are associated with those?
Yeah, so at this stage, immunosuppression is lifelong. We have not established what we call immunotolerance in the pediatric liver transplant for the recipient. Our goal is to maintain them on the minimum amount of immunosuppression to prevent rejection and reduce the risk of infection or risk of malignancy. So the monitoring become less frequent after the first year post-transplant. We do monitoring every 3 months only if the patient is perfectly stable, and we see them annually. So we try to transition them to a more normal lifestyle as long as their condition allow and they are stable. And it's a partnership, so we work with them to accommodate their schedule and their preference and style. But at the end of the day, our goal is the same, is to just have healthy liver transplant recipients.
You mentioned rejection. Can you talk a little bit more? What is that? And how often does it happen?
Yeah, so I can start and turn to my colleagues. So rejection is when the immune cell in the body kind of reject the new liver. It recognizes it as non-self and try to infiltrate it and cause liver injury and liver damage that, if left untreated, might cost us the graft. There is an acute form that happen mostly during the first 2 months post-transplant, and there is a chronic form that's most likely secondary to poor adherence to the immunosuppressive regimen, among other causes. We refer to this condition as late graft dysfunction sometime. And the way to prevent this from happening is, adherence to the medical therapy, frequent monitoring. These are the main things. And
compliance is going to be incredible. It's really hard after having a transplant to stick to that schedule. We have fantastic transplant pharmacists. We have fantastic coordinators that just go with the family, give them booklets, make it as easy as possible. We try to explain to the patients why this is important, and we try to keep it in ourselves, because if a kiddo or if a patient had biliary atresia and had a transplant at 2 years of age, and now we're seeing him and they're 14, then they really need to understand what happened. Why are they taking this medication? Why is it very important for them? What does it mean to have a liver? How do we treat this gift well? How are we respectful for it? And I think that's the major point.
Absolutely. What are some of the things that get in the way of a patient not remembering to take their medications, or because you guys say compliance, but for the non-medical people, that means just not being able to take your medications as prescribed, correct?
Correct. Absolutely. Yeah. So how can we help them with that? We
Mhm.
try to do, so we try to pare down, if they're having any difficulties, we try to see what medications are the most important. We go over and review the charts and how are they taking their medications, see if we can lump some together, decrease the frequency of them. And then when we are at the tail end of the medication, we are usually reassessing, do we need this? Do we not need this? And we review medication lists within every visit. And this is reviewed with the coordinator, but also us, so that we can see, is there any problem? Are there any concerns? Is this giving you a side effect? Or does your tummy hurt and you don't want to take it because of that? How can we make it better? And sometimes we notice that they're on this medication for a little bit longer, it carried on, and we just stop it, and that helps.
Yeah, I would imagine so. Well, we are at the end of our time. Do any of you have any closing thoughts that you'd like to share about liver transplantation and liver failure in children?
So, the success of liver transplantation, as we outlined, is a team effort. It's us and the patient and their family, and we believe in that, and work with the families to achieve this goal. Close communication is always, a path to success. And we believe we can address any complication if identified early on in the process in a timely manner. And this is what we strive for. We try, for example, to biopsy a patient the same day we discover that this is most likely to be a rejection. So we work closely to, work in a timely manner and address the modifiable factor. There are some stuff that are beyond our mean, but we always strive to address what we can address as soon as possible.
There are many patients we follow whom were transplanted as infants. They're now in young adults. There's nothing greater than seeing them having succeeded and then having a near normal life, pretty much normal life.
Yeah.
And the annual is a reunion for my patient who I've cared for when I was in training. It's really rewarding, as Dr. Hassan said. So,
Yeah. And as always, love your liver and donate life.
Make life. That's the main message. So, we can help more patients live a healthy and happy life.
Yeah.
That's a great message to end on. Thank you, all of you, for joining us and sharing your expertise about liver failure and liver transplantation in children. Thank you, everyone who watched and listened and sent in questions. You can catch the next Ask the Mayo Mom on April 1st, and we will be discussing updates on the COVID-19 pandemic at 11 a.m. Central Standard Time. We will be joined again by the fabulous Dr. Emily Levy and Nipuni Rajapakse, or Dr. Nipuni Rajapakse. Thank you, everyone. Have a great day. Remember to be safe, wear your mask, and get your vaccinations for COVID-19 when it's available to you.